Good evening, everybody.
Good evening, Stu.
Thank you. You know what tonight is?
Your birthday?
No. Tonight is our 24th program of this year.
Wow. Nice.
Yeah, I heard a wow. That was good. And yes, I remember once. That's good too. I like hearing clapping. Everybody else want to do that? There you go. So for those that don't know, because I do see some new faces in the room, my name is Stuart Schlossman, and I too have multiple sclerosis. And that's how this all began, but that's another story, and we can't get into that anymore. So it's not about me, it's about the organization, okay? So going forward, though, MS Views and News provides educational information for those affected by MS. Being affected, you are not just the patient. You can also be the caregiver or a friend or just another family member that needs to know what's going on with you, so that way when and if you might be having problems, that others can recognize this, what's happening with you. So we also hope that other healthcare providers that are in the industry or having to do with multiple sclerosis can see also what is happening. Maybe they are new. Maybe they're a physical trainer or a physical therapist or an occupational therapist or something to do with multiple sclerosis that they need to learn more about. Well, these educational programs that we're doing will hopefully be able to teach them what is happening. And so if you go to like our YouTube channel, we have the MS Views and News Learning channel on YouTube. We have over 150 programs right now on that website. All right, you go to YouTube, you type in youtube.com/MS Views and News, or you go to where we showed you at the beginning, where there's the blogs and the videos, and you click on that from the website. You'll find the videos there, whether it be about urology or about MS or about the symptoms of MS or the impact of MS on the family or about neuro-ophthalmology, and that's about the vision, okay, or about anything, realistically, anything about multiple sclerosis, you will be able to find on that learning channel. And again, you could share that with family and friends, or if you do not remember what's happening at tonight's program, you'll be able to see this in about a week from now. So again, just remember to share it with everybody, share it with yourselves, and use it for however you can. Listen, tonight's program, like all of our programs, are funded by a pharmaceutical company. And so for tonight, I would like to recognize the funder of tonight's program. That would be Genzyme, a Sanofi company. So I hope all of you will thank them for being here tonight. Thank you. In addition to Genzyme, we always have our sponsors that are out in the hallway, and they're there to be able to provide you with information that you might need to know about the medications that they have. And so we always want to thank them as well, but you probably did that when you visited their tables. Tonight's format, without getting into a lot of things about MS Views and News, but tonight's format is different than we've done in the past because we have somebody speaking tonight that we've never had speak at one of our programs, and that is Michelle Alva. Okay, and she will be speaking with you. She's our second speaker tonight. Look, she gives a good hand for herself back there. That's great. All right, first we have Dr. Baker. I'm sure a lot of you here just because you want to hear Dr. Baker again, right? You want to hear about all these different medications that are out there, and that is exactly what he's going to bring to you. But he's not just going to speak about that. He's going to speak a little bit about the impact of MS on the family or the self aspects of MS, all right, and what it's doing to you and how you can be better yourselves. Okay, so then we're going to have Michelle Alva, and she's going to speak about a new complementary therapy that she's going to have for you. And I've heard her do this before, and I really, really think that you're all going to like it as well. And then, for the ladies in this audience, I know you're going to love the last person speaking, because that's Jeff Siegel. Oh my God, he's already got a round of applause. Yes, Jeff. The women out there love hearing Jeff, and I hate him. Yeah, no, I'm just kidding. All right, but Jeff is here, and Jeff is going to get you out of your chairs, and Jeff is going to work with you on showing you how to hopefully help you decrease if you have any spasticity pain. All right, Jeff is going to show you what you have to do to reduce this, as well as just to better yourselves with a little bit of adaptive exercise. All right? So without any further ado, let's welcome Dr. Baker. He's coming on down.
I'll share a story with you. When I was a senior in high school, I played basketball, and sometimes we would have Saturday morning practices. They they were rough. Saturday morning practices were rough. This particular Saturday, I'd been recruited to be an usher in a wedding. I think because my parents were friends with this couple and they needed an extra body. They needed a warm body. Well, they were into videoing everything. And so I was dehydrated. I didn't eat lunch. They put me in this monkey suit. And I had to show people to their seats. And then after that, I had to stand up in front of a church. And there was a light just like this one. And I'm standing there, my knees locked, and the light's shining bright in my eyes, and I feel just this wave come over me. Then my vision did this, and then I rocked back and forth, and I completely passed out on video at this wedding. And thankfully, this was before like America's Funniest Home Videos and YouTube, and because it must have been hilarious. Well, the story doesn't end there. A few years later, I get invited to be a groomsman in my college roommate's wedding. Same thing happens, only at the reception. We're all standing in front being welcomed, and the cake's right behind me. Narrowly averted the cake, passed out again. Fortunately, I made it through my own wedding without passing out, but it was close. It was close. But thank you for having me here. And if I pass out, you know, the preface there is if I pass out, are there any medical professionals here or anything? Okay. Oh, yeah. Oh, hi. Yeah, good. Thank you. I'll come to you. Don't need to call 911. I'll come around. So Stu asked me to give this talk, and of course, in typical Stuart fashion, he gives me a list of 18 or 20 things to talk about in 40 minutes, 16 of which I know nothing about, so I'll focus on 2 of those 18 to 20 things. But, you know, I was looking at the impact of MS on the individual, the family, but I also really wanted to put a positive spin on it because we can impact MS. Not only does MS impact us, but we as patients, physicians, caregivers, healthcare providers, in whatever role, can impact the disease course and the outcome of MS. And we're fortunate enough to be living in a time when we have therapies for MS. When I started treating MS patients, I was lucky to have 3 medications that altered the course of the disease. And we didn't know a lot about how to use those medications at the time, but we learned. And now I think we're up to 12 plus maybe 13 disease-modifying therapies, and we have some symptomatic treatments, and we know a lot more about how to manage and affect the course or impact the course of this disease. So just as an overview, we'll go over some MS basics. MS is an inflammatory, immune-mediated disease, and it's characterized by attacks of neurological dysfunction and progression or accumulation of neurologic dysfunction throughout the years. It's a chronic disease. It doesn't really go away. Now, why do we say immune-mediated? Some people might be more familiar with the term autoimmune disease. Well, in MS, we don't know exactly what the trigger is. We think that it's caused by some environmental trigger which is superimposed on a genetic predisposition. We inherit our immune systems from our parents. We get some from mom, some from dad. It gets all mixed up in the DNA, and then we're exposed to certain environmental challenges and triggers, you know, certain viruses, bacteria, parasites, whatever it might be, and that shapes or forms the way that our body's immune system responds to certain challenges. It is the major cause of non-traumatic disability in young adults in the United States. It affects 400,000 people here and 2.5 million people worldwide. Well, what's the age range that it affects? I was always taught MS affects people 5 to 80, and that's about right. We see people as early as age 5 and as late into their 80s being diagnosed with MS, but that bell-shaped curve where most people are diagnosed is between the ages of 20 to 50. It's mostly a disease of young women, but men are affected in a ratio of about 2.5 to 3 to 1. And so it really hits people in the prime of their life. This is a time when you're developing relationships, you're getting married, you're building a career, you're just peaking in your career, and it can be extremely impactful on those aspects of life: relationships, job performance, professional development, productivity. So what is disease activity in MS? Well, in MS, we measure disease activity in frequency of relapses, also known as attacks or exacerbations. And these symptoms may resolve, but what we're learning also is that 40 to 50% of the time, the symptoms don't resolve entirely, and there is residual disability as a consequence of these attacks. And that's coupled with disability progression. So not only can you have incomplete resolution of the attacks leading to worsening or progression of the disease, but underlying that there can be a slow progressive neurodegenerative component as opposed to an inflammatory relapse or attack. And we also look at MRI lesions. So when one goes into the MRI scanner, oftentimes, maybe 95% of the time, the technician will come in and administer a little contrast dye into the vein. And what that shows is it shows the neurologist and the radiologist areas of active inflammation. This is a lesion or a spot that is actively inflamed. It's an acute lesion. But we also look at a certain sequence on MRI called T2 lesions, which can be new, or they can be old T2 lesions that have enlarged since the last MRI scan. And that also gives us an idea about what's happening and what has happened. There's another type of sequence that we look at called a T1 sequence, which shows us footprints of chronic damage that have occurred in the past. And those are areas of irreversible axonal loss, we think. So these are areas of chronic scars that are not coming back or not resolving. And then in some studies, we look at brain shrinkage or atrophy. So all of these things together indicate MRI, quote unquote, activity. And then when you have your physical exam with your neurologist and your neurological examination, they sometimes will perform certain tests that they put together in a scale called an EDSS. And that gives a number, and that number correlates, the higher the number, the more disability due to multiple sclerosis. It goes from 0 to 10. So as this is an introduction to the things that we look at as physicians and the things that we need to be aware of as patients in measuring disease activity. Now, in general, there are considered to be 4 patterns of MS. MS is variable in the way that it progresses with time or changes with time. It's highly unpredictable. And this is a first pattern that some of you may recognize this. This is on the y-axis here is neurologic disability, on the x-axis is time. So with a relapsing form of MS, or relapsing remitting MS, you have these attacks of neurologic dysfunction with resolution, and then another attack separated in time with resolution. And then here's an example of where an attack occurs, plateaus for a little bit, and then there's incomplete resolution leading to accumulation of neurologic disability. And then, let me slip around this microphone here with my hand, another attack, and then incomplete resolution, followed by a progression. So this would be a typical relapsing remitting multiple sclerosis followed by a secondary progressive stage with superimposed relapses. Now, this line here illustrates a more progressive form of MS. This would be a primary progressive disease where you have a slow accumulation of neurologic disability. There can be plateaus with time where there's no change, followed by further progression. Sometimes things can get better temporarily, and then further progression. And this graph here, I think my battery ran out on the pointer here, but I'll give this to you. Thanks. The third line there demonstrates a course where there is a slow progression with superimposed relapses, or a relapsing progressive course. And we'll pause for a second and get some batteries. Now we can tell, is it working? Oh, go ahead and advance, thank you. Yeah, I didn't hear you. So in the past, we've sort of talked about these 4 disease types. So the relapsing remitting MS, the primary progressive MS, secondary progressive MS, which most patients who are left untreated will go on to develop if they start with a relapsing remitting form of MS, and then a progressive relapsing multiple sclerosis. Now, patients come into my office and they'll say, "Doc, what type of MS do I have?" And it can be confusing sometimes. And I think looking at this graph, how many of you out there kind of feel a sense of being overwhelmed by the number of lines on that graph and the different terms? Yeah, I know I do, and I know it's hard to explain sometimes to patients. So we're trying to change the way that we classify subtypes of multiple sclerosis. And I call this the KISS model. And you've heard this before. It's a keep it simple, stupid model of classifying multiple sclerosis. So this is our Venn diagram from ninth grade math class, right? So we really divide it into activity and progression. And so either your MS can be active, and by activity it can be relapses or attacks, that's defined as activity, or it can be new MRI lesions, those contrast enhancing lesions that I talked about before, or those accumulation or enlarging new T2 lesions. And then we also look at disease progression. So not only can you have activity, but you can have disease progression, either in that slow fashion that you saw on the graph before, or with a attack and then incomplete resolution. So within this Venn diagram, you can either be active without progression, you can be progressive without activity, or you can have a combination of the two things. Now, everything outside here in white is good, right? Because there's no activity, that's what we want, and there's no progression of disease. That's ideal. So what we look for in treating MS is we look for no progression, no activity. And that can either be a function of the individual's disease process. Some people will be quiescent for a while, no progression, no activity, like we saw with that flat line on the graph. Or it can be a reflection of doing a good job with disease-modifying therapies. So what are the neurologic symptoms of MS? You've probably heard this many, many times, but I'll go through it in the spirit of providing a springboard for further discussion later on in this talk. But there's numbness, weakness, loss of balance, unsteadiness, visual loss, double vision, pain, fatigue, cognitive impairment, bowel or bladder dysfunction, and sexual dysfunction. And that doesn't include all of the symptoms, but those are some that patients frequently experience. And depending on the site in the nervous system that's affected by these lesions or inflammation, people have different symptoms. So if the cerebrum or the brain is affected in general, we see cognitive dysfunction, memory problems, executive dysfunction, decision-making problems, attention, concentration issues. If the visual pathways are affected, people have painful visual loss in one eye or the other, and that's called optic neuritis. If the brainstem is involved, we see double vision, imbalance, unsteadiness, something called pseudobulbar affect, which is difficult to recognize sometimes. It's an over display of emotion in an inappropriate way, and it can be very socially disabling and uncomfortable for patients and their family members. Slurred speech, or the doctor term for that's dysarthria. If there is a lesion in the spinal cord, one might experience weakness, spasticity, sensory loss, bladder, bowel, sexual dysfunction. And there's some other more non-localizable symptoms of MS. We don't really know where they arise from, but fatigue's a big one, temperature intolerance, and pain can occur as a consequence of involvement in almost any area of the central nervous system. For instance, inflammation in the optic nerve causes extreme pain in some patients with optic neuritis. And then the back part of the brain, we call it the little brain or cerebellum. The pathways in and out of the cerebellum cause ataxia, which is fancy doctor talk for imbalance and unsteadiness, tremor, and speech disturbance. There's a very characteristic speech pattern of someone who has a cerebellar lesion. So what's the impact of MS? Well, based on this disease activity, relapses, which are extremely unpredictable, and there can be new neurologic symptoms which you've never experienced before, and so you're learning to deal or understand what's happening to your body and your nervous system really has an impact on your life. Or relapses can be a worsening of an old symptom which is not due to some obvious cause like fever, infection, stress, sleep deprivation, medications which might be new for you that you're having a hard time tolerating. And then progression certainly impacts the individual with MS due to loss of function, loss of productivity, loss of independence. As far as the impact of MRI lesions, my statement is there is no there are no good MRI lesions. There's sometimes a disconnect between MRI and the clinical presentation of MS, or how a patient is doing clinically. I've seen patients frequently that will have a completely stable MRI, no change in it, but they're doing worse. And the opposite occurs. You see patients with worsening MRIs, and clinically they're doing very well. So from an MRI standpoint, there's often a disconnect between those two things, but MSologists, MS experts believe strongly that MRI does reflect disease activity, does have an impact down the road. It's probably that we're just not good enough at picking up the subtle differences in the physical exam or recognizing the ultimate outcome of what those lesions or disease activity are doing. And then we have the symptoms of MS, which, depending on what they are, and I'll go over those a little bit later, interfere with your activities of daily living, your social interactions, the hobbies, things you want to do, recreational activities, and your relationships. So what's the social impact of MS? Well, there was a study done in the UK that showed that over 50% of patients with MS give up their jobs. That to me was startling. 50% of patients. 1/3 of those patients suffered a decline in their standard of living. So you imagine if you have a 2-income family, someone quits their job, goes on disability, income drops. You have to alter your lifestyle. You have to alter your standard of living. Surprisingly, to me, because I was always taught that MS divorce rates were higher. And the data shows that the marital status remained the same, which was shocking to me. And we have to ask ourselves, why is that? And it's said that it might be that in the face of chronic illness, that people may remain loyal. They don't want to leave their partner who's suffering with a neurologic illness. People may stay together, they may stay married to maintain or retain their health insurance. I like to think that, they said, they made a vow and they stuck with it. But if you look at the literature, there's some reasons why people stay married in these circumstances. Now, the other thing that I learned when Stu asked me to talk about this was that there is a difference between divorce rates depending on which partner is affected. So if the woman is affected, the divorce rate is higher, so upwards of 21% or so, which is low compared to the average divorce rate, right? If the man is affected, what do you think the divorce rate is? It's low, very low. It's like upwards of as low as 3%. So there's a definitely a gender difference there in the divorce rate in couples who are affected by MS. The professional career of the relative or a relative is affected about 57% of the time. So not only does it affect the individual with MS, their professional career, ability to maintain their employment, their ability to make a living, but it also affects the professional career of the other, or the spouse, or the significant other, or the other person in the household who is responsible for being a caregiver. Now, work and social interactions correlated with cognitive function and disability. So the more cognitive impairment and the higher the disability scale was, the more impactful work impairment and social interactions were. So there's a tendency with cognitive impairment for patients and their caregivers to withdraw. And so you're not as social, you're not going out as much. And that makes sense. But this study demonstrated all of those things. Now, spouses, significant others are certainly affected by this disease, but children are too. And a question often arises, how do you tell your kids? When do you tell your kids? Very, very difficult situation. And it's hard to think about. It's tough to go through these discussions with kids, and we forget how smart these little ones are. Probably around the age of 4 or 5, they start to be extremely intuitive that something's wrong, something's going on. It's different for everybody. And your discussions with your children about MS and the method in which you disclose your diagnosis to your children, or it's different for different ages. And you might have kids in different age groups. So you talk to a teenager differently than you talk to a 5-year-old. So communicate in an age-appropriate way. Open the door. Let them know that you are ready to talk when they are. For younger kids, be extremely concrete. It's hard enough for spouses to understand MS fatigue and how it impacts MS patients, and to really wrap your head and your hands around that symptom. Imagine how difficult it is for young kids to understand MS fatigue. So if you have to use something else, that's okay. If you have to say, Dad has a headache, I got to go lay down for a little bit, when they're really young, that's all right. You're not really lying to them, but you're explaining that you have a symptom that they can really understand at that point. And as they grow, you can disclose more and more information. Involve them in the treatment process. I think that some people are worried about their kids seeing shots and needles and injections, and they sort of try to hide it from them. Might not be the best thing to do. I have a distinct memory from being 5 years old visiting my grandfather, and I walked in on him, and he was giving himself an insulin shot. And the most traumatic thing about that wasn't the shot or the needle, but it was seeing my grandfather's white butt. I mean, that sticks in my head. I thought, man, that's scary. But the needle, he talked to me about it, and he told me what he was doing, and he kind of explained, and it was okay. And maybe that prompted me to get interested in medicine later on. But they're really, really smart. So involve them in that treatment process. As they get older, you can bring them to the doctor, even if they're younger. They can, and if your doctor's open to that, and they can concentrate with a 4 or 5-year-old running around the office, that's fine. Now, if it distracts from or detracts from your office visit, probably not a good idea. I happen to be the kind of doctor that does not hear children's voices or screams. I just don't hear it. I don't hear crying babies. I never woke up once as my kids were, babies. It's just that there's a filter there. So I can completely concentrate and do a clinic visit, and there can be 3 kids running around the exam room. But some doctors might not operate that way, and that's all right. We have to respect that. So just clear it first, and if certainly they can be involved in that. It's not going to scare them. It's not going to frighten them away. So the way that you approach disclosure of your MS and your disease process, and the openness with which you approach this, actually frames and shapes the way that they deal with problems and how open they are in the future. So get help too, because it's not easy. Consult with a counselor, consult with a psychologist, talk to somebody in your church group that may be a counselor or has some experience with this. There may be a family member who has particular expertise at delivering information to kids. The National MS Society website is an excellent resource for material to help children understand what's going on with MS. They have a teenager book. They have a series of articles or journals, really, or cartoon books. I think it's called Keep Smilin' with an apostrophe MYELIN, like Mylan, and it explains MS and explains how their parents might be feeling. So there are resources available for that. So, and parenting with MS can be challenging too. It's important to be flexible. Plans change. You might think that you're going to have an all-day trip to Disney World in the middle of August with your kids. It might not happen the way that you plan. So, just be flexible. And if things change, you can be disappointed too. You don't have to put up a front. You can share with them that, man, I really wanted to do that with you, but it just didn't work out this time, and we'll try something else later. Have some backup plans available. Have a plan B. So if plan A doesn't work, have something fun planned as a backup. As parents, we always want to do something. We always want to make things fun for our kids. But what we don't realize is we don't have to do. We just have to be sometimes. Sitting and cuddling on the couch and watching cartoons, whatever show they want to watch, is incredibly valuable to your children. Illness often can provide more time for people to be present for their kids. When you're working 80 hours a week, you're just not there for them. So sometimes having an impact of an illness like multiple sclerosis can make you more present for your children, actually strengthen that relationship. So be honest and open, and your approach will shape their ability to communicate these things later. Now, when Stu asked me to do this talk, I thought, I really don't address these things with my patients in that 15-minute clinic spot or that 30-minute clinic spot. There's just not enough time. You're worried about laboratory tests that might be abnormal. You're worried about JC virus antibody status. You're worried about what medication to use. You're refilling medicines. You're dealing with EHR, typing things into computers. You're trying to address the things that are most important to your patient at that particular time. So I started asking my patients, I said, how has MS impacted your relationship with your blank? You fill in the blank, boyfriend, girlfriend, children, husband, wife, significant other. And these are some of the answers that I got. I felt bad that we can't do the things we had always planned to do. I just don't want to be a burden. I feel guilty that I can no longer keep up with my responsibilities in the house. Guilt was kind of a pervasive theme in all this. This one was, she said, my boyfriend was afraid that he would break me. And we had a laugh about that. You're not going to be broken. But this was sort of reflecting on intimacy issues in MS. And when she was diagnosed, he wouldn't touch her. He backed away. And she felt that he found her unattractive. And that was sad. But what it was, and he was there at this visit, he said, I was just afraid I would hurt her. I didn't know. I just didn't know. And they got over that. But these are some really impactful statements. I can't wait for Thanksgiving Day so we can eat real food. Think about that. So there's one day a year where this person has the energy, or at least gets together the energy or fights through it to make real food. The rest of the year, it's takeout, it's TV dinners, and the family looks forward to that. So you can kind of approach that in two ways. It's sad in one respect, but man, I bet Thanksgiving's amazing. It's my favorite holiday, incidentally. If anyone wants to invite me for Thanksgiving, I'm open. I'm glad my kids are healthy and I have MS and they don't. So let me, I'm thankful that I can take this burden. I can hold on to this and my kids don't have it. I'm no longer the go-to guy in the family. That was a tough one to hear. So here's a guy that anytime there's a problem, big extended family, anytime you need your roof fixed, you need your carburetor changed, you need money, you need a check, you need a loan. I'm working, I got cash, I'm flush with it. Come to me, I'm your man. MS hits, disability, no job, physical disabilities, no longer the go-to guy. That was tough. Some people describe themselves as being perceived as being lazy, and then guilt was a big one. This one was really good. I put it last. This is her speaking to her significant other, and she said, "You didn't plan on this. I didn't plan on this. We didn't plan on this. But if we love each other enough, we can adapt. We can make changes. We can do the things that we want to do if we really commit and love each other enough to do that." So let's talk a little bit about how these symptoms impact our lives and how we can change the way that we let or allow these symptoms to impact us. Probably the two biggest symptoms in MS that affect us, that most patients say provide a certain high level of impact on their quality of life, is number one, fatigue, and number two, mobility issues. Fatigue's kind of that invisible, poorly understood symptom. And it's not just tiredness or fatigue, it's like getting hit by a Mack truck. Out of the blue, knocks you out. You're just laid out. There are medications that can be helpful for that, but it really takes a lot. It takes energy conservation techniques. It takes a regular exercise program. It takes a good, healthy diet. It takes timing. You have to know when your good times are during the day. You have to know when you're going to get fatigued. You got to rest. You got to talk with your healthcare provider about certain medications that might be exacerbating your fatigue and certain medications that might be helpful in alleviating your fatigue. Mobility issues, man, those are hard to manage too. It's one of those situations where you have to plan ahead, right? You really have to think about things. I have a patient that just went on disability, and he shared with me recently that he's enrolled in school. He's going to university. He's picking up a different career. Career that he had before just wasn't in keeping with his physical situation. But he has to think about getting to school, finding a parking spot, getting his wheelchair out. South Florida, it's going to start raining. He's going to get wet. He has to find the ramp. He has to find the, first thing he does when he rolls in is find out where the restroom is. All of this, it takes him so much more effort than it does, a regular, 22-year-old college student without any disability. Utilize physical therapy for your mobility issues. Don't be afraid of assistive devices. If you need it, use it. It's going to be so much better for you. It will conserve energy. It's safer for you. You'll have more energy to devote to other activities. And there are some medications that can be helpful for mobility issues. If there's anti-spasticity medications can be useful. There's a walking pill. David was out here earlier. Ampure or dalfampridine can be effective in a lot of patients who have mobility issues with MS. Cognitive dysfunction, sometimes tough to recognize. It's insidious, meaning it's sneaky, sneaks up on you. It's very, very frustrating. So utilize techniques to improve cognition by brain exercises, write things down, utilize your smartphone technology, of course, and pick a disease-modifying therapy that is right for you and stick to it. And we think that treating this disease early and being adherent to therapy is extremely important in protecting the brain later on. Diet, exercise, wellness program. And then sexual dysfunction certainly impacts relationships. I think back to my medical school days when we had a lecture on sexual function, human sexual function. And there was a professor of OBGYN who came in to talk to us. And I don't remember his name, but he was an old guy, a little older than me. And he said one important thing. He said, you have to not be embarrassed to talk about it with your patients. You have to be open and honest and not be embarrassed. Because if you're embarrassed, they're not going to tell you about it. And then he spent the next 55 minutes referring to the human genitalia as, quote unquote, the area. He couldn't even say the word. So, yeah. But, be open with your partner about what's going on with your body. Be open with your doctor. These are uncomfortable things to talk about. They really are, but they're extremely important. We know that human beings in general with active sex lives are healthier and live longer. So sex saves your lives. Women, write this down. Husbands, make sure they write it down. Now, definitely there's some gender differences in MS. Men with MS have different sexual issues than women with MS. There's some great information on the National MS website about sexual function in patients with MS. And what they encourage, again, is be open, be honest, explore your bodies, find out what hurts, find out what's painful, and don't do that, right? And find out what feels good. Your bodies are changing. Don't be afraid to redefine sex. It's not just intercourse, okay? Redefine it. Utilize toys. Utilize lubricants. Vaginal dryness is common in multiple sclerosis. Spasticity and tightness can impair the ability to have sexual intercourse and sex with MS. So stretch. But it can be exciting, right? It really can. So you can explore all these new things. And remember, talk to your doctor about it. Talk to your healthcare provider. Talk to your partner. Be open. Don't just say the area. Bladder dysfunction, frustrating, limiting. Oh, man. Time your fluid intake. Talk to a urologist. There's medications, bladder training, have backup plans, use pads, use adult diapers if you need to. If you have an accident, have some clothes available. Don't be embarrassed. Not your fault. Unfortunately, with MS, sometimes when the spinal cord is involved, when those pathways to the bladder are involved, it happens, and you don't even know it happens. Sometimes you can't feel it. Same thing with bowel dysfunction. There's some nice articles online, and there's some resources that go through this. Urologists are excellent at defining what type of bladder dysfunction is present and helping you manage it. MS spasticity, MS pain comes and goes, worse at certain times. There are certain irritants that make it worse. PT, stretching, medication management, all key. So the point of this is there are all these symptoms that really impact professional functioning, social functioning, hobbies, activities, relationships. But if you take a comprehensive approach to each one of those and just chip away at them, you certainly can impact them and reduce them significantly. Now, how else can we impact MS? Change the course of the disease. We have, I think, 13 disease-modifying drugs at this time, 13 different ones. There's not one drug for everybody. If you have a relapsing form of MS, there's going to be a medication that you can tolerate, that you can adhere to. Pick one that works with you. Pick one that works for you. Go to your doctor's appointments routinely. Get routine MRIs to assess the effectiveness or efficacy of those disease-modifying therapies. Give it time to work. This is a marathon. These drugs take a while to kick in sometimes. And it's hard when you bounce from one medication to the other one. So be patient. I know it's hard, but be patient. Treat relapses. Relapses are bad. If you treat them, they resolve more quickly. We have ample data that shows that. You can get back to your life more quickly. Have a relapse plan. So know what a relapse is and what it isn't. Define what it is. A relapse is a new neurologic symptom that lasts for more than 24 hours. Or it can be an old neurologic symptom that's worse that lasts for more than 24 hours. And it's at least 30 days after your last relapse. If it's within 30 days, it's all part of the same relapse. Relapses can last and last and last. They can last up to 6 months sometimes. Have a plan in place to treat it. Know how to get in touch with your doctor. I should qualify the definition of relapse as it has to be in the absence of something that is obviously provoking an old symptom to be worse, like fever, infection, fatigue, sleep deprivation, stress, etc. There are medications available. There's methylprednisolone, the IV Solumedrol. Sometimes we can give methylprednisolone in pill form, and there's Acthar, which is a medication you can administer to yourself that helps speed up the recovery from these attacks. But have a plan in place. It's also important to kind of track your health status along the way. Keep a journal. Keep it in a book or on your smartphone so that you recognize when there's a change, when it is a new symptom. If you've had facial numbness before, and then you get it again, but you don't remember that you had it before because you hadn't charted it. But if you have it in that book, you're like, oh yeah, I did have this. And this is what happened, and this is what I did. Well, this is the same thing. And then you can kind of know where to go from there. But if it lasts more than 24 hours and there's no other reason, that's a relapse or an attack. It's also helpful for your doctor to know how often you're having these relapses, because it might change the way that he or she treats you with a disease-modifying therapy. And then actively engage in a good health and wellness program. Above all, if you smoke, please stop smoking. Please do it. Best thing you can do for your MS. We know that tobacco, cigarette smoke worsens MS, increases the likelihood of progression of disability, increases attack rate, makes MS worse. Develop a team around you. All right, it's not just you. You're not alone in this. So involve your family, involve your healthcare provider, get a urologist if you're having bladder problems, if you're having depression, anxiety, involve psychology, psychiatry, nutritionist, talk with someone who knows a lot about diet, nutrition if you need to, local support groups, consult with MS Views, wonderful resource. Physical therapy, talk with an occupational therapist about energy conservation techniques, extremely important. So in summary, MS is an immune-mediated disease that is unpredictable, variable in course, with respect to its disease activity and progression. It's different for everybody. MS is a major cause, the major cause of non-traumatic disability in young adults. Remember, young adults involve themselves in a lot of risk-taking behaviors, skydiving, riding motorcycles without helmets, that sort of thing, skateboarding. So a lot of accidents occur. So the number one cause of disability is trauma in young adults. Second most is MS. Has a significant impact on work, productivity, and relationships. Remember to be open, honest, age-appropriate in your discussions with your children about your disclosing your diagnosis of MS and what it involves. But there's help available for that. And management of lifestyle, MS symptoms, disease modification, treatment of relapses can be effective in you impacting the ultimate outcome of MS and your quality of life. All right, with that, I'll entertain some questions. And Stuart, do I need to say something about it?
No, I just got to get a mic.
Oh, he needs some.
Firstly, let's thank Dr. Baker.
Thank you.
Anybody have a question? Any questions? Somebody's got to have a question. You didn't just come here for the food. You came here for questions.
This is the part where I say, if they don't have questions, I mean I did a really good job in answering them beforehand, right? All right.
You know, when I used to be a patient advocate, they counted that against me.
Really?
Yeah.
You got no
they wanted
questions?
the advocates to have questions being asked of them.
Don't mark me down on your evaluation form.
On one of the slides, it mentioned MS pain, and then there was another word, began with a P, I think.
Oh, I don't. Let's see.
Yeah.
Oh, yeah, comes and goes. Yeah, that's fancy. It's hard for me. I get these fancy doctor words. You know what? That's why we make so much money. We take a regular word and make it fancy, and no one understands it. Yeah. Yeah, that means it comes and goes. So I don't know. Some of you remember may have been diagnosed when, the doctor would say, there's good news and bad news. The bad news is you have MS. The good news is you'll never have any pain from it. It's not painful. Oh, boy, were they wrong, right? But, there's certain syndromes in MS. Like one of the things that can be very painful is when you bend your neck forward and you get that shooting electrical pain and discomfort down your neck and spine and arms. There's one that's really bad called trigeminal neuralgia, where there's a shooting electrical pain down the jaw that happens not infrequently in MS. Neuropathic pain, the burning, tingling, hands, feet. Remember the MS hug too, the not the good kind of hug, the anaconda around the abdomen or the chest. So MS can be very painful, but that pain can be managed, and there are medications that can be very helpful, and certain techniques can be helpful in managing that.
Hi.
Put up to your mouth.
Question. What is being done, or what do you know is being done as far as research in cannabis with MS?
Should we have an entire lecture on that, Stu, at some point?
If you'd like to do it, you got 10 minutes right now. Go for it.
Well, the last thing that I read was that the American Academy of Neurology did a review of complementary alternative medical therapies, or I shouldn't say that's complementary alternative therapies in MS, and their summary findings was that cannabinoids and cannabidiols were effective in treating MS pain and spasticity probably, and maybe bladder dysfunction probably. More research is needed. It's unfortunate that there's such a political component to this, but what I know, and I may be off on the numbers a little bit, so there are probably about 64 active compounds in marijuana, chemically active compounds, or biologically active compounds, I should say. The tetrahydrocannabinol, the THC, that's the good stuff. That's the stuff that makes you feel good, right? I don't know anything about that, but the stuff that probably works on your nervous system to help you with spasticity is the cannabidiol. And so, the thought is if we can get more of a ratio of cannabidiol to the THC, then we can minimize the cognitive effects. There were some studies that were done on spasticity and MS, and the result was patients with MS who use marijuana feel better. I think a lot of people who use marijuana feel better. That's why they use it. But you don't want to. That's the problem. Yeah. You can't talk about it. Yeah. So you want to be. You have to balance, like with any therapy, you have to balance side effects and effectiveness. And so if smoking marijuana improves your spasticity and helps you walk better, that's great. But if it's helping you walk to McDonald's to eat 16 Big Macs because you have the munchies, that's not a good thing either on your cardiovascular system. But I think at some point we're going to have a compound from the marijuana plant that is helpful for neurologic symptoms related to MS. So, good question.
Okay, next question.
Can you speak to the latest study that they're doing in France? They're in the third phase, I guess, with vitamin D3. They're suggesting, or they're using 300 milligrams.
Oh, that might be the biotin study. Is that the
I'm
biotin?
sorry,
Yeah.
I'm sorry. Yes, it's the biotin.
Yeah, it's a biotin.
I'm
So
sorry.
they're using
Yes.
300 milligrams.
Yes.
Yeah.
Yeah, I take 10 milligrams, and I think that's a lot.
You probably, so you're taking the 10,000 microgram pill.
Micrograms, yeah.
No,
Yeah.
you're right. I think
Yes.
so. So they presented some data at the last AAN meeting, which suggested that it seemed to be safe, and they saw some good numbers with reducing disability progression, and so that's a platform for a phase 3 study. So we're looking forward to that. It's not an entirely benign compound, so there can be potentially some teratogenic effects of biotin, so it can be harmful to unborn children. So that there's not, the safety isn't there to recommend it in general, but it's exciting. It's exciting information. We like to see positive results like that, but only a good phase 3 trial will give us the answer. Unfortunately, I think that I bought some biotin because I'm losing all my hair, and it was the same thing that you bought, and I think it was like $10 at Walmart or something. So to get that, it's going to be $300 or to get up to 300 milligrams. So it's expensive at this point, but good question, yeah.
Is there a certain level of a minimum? You keep coming closer.
I gotta hold that close.
A minimum you would take somebody off a medication for the lymphocyte count?
Okay, so the question surrounds lymphocyte counts and medications. So it depends on the medicine. In part, and it depends on whether or not the lymphocyte count is sustained. So if it's low for a couple times. So, the general rule is if it's below 500 or so, with certain medications in the package insert, there's a certain oral medication that if the lymphocyte count is sustained below 500, then it's recommended that the physician and patient interrupt therapy. So we're learning that suppressing that lymphocyte count can potentially lead to certain opportunistic infections or infections that otherwise would not be present in the body. But as a general rule, it's 500.
Repeat.
So would that translate to 0.5? Yes, that would. Yeah. So there's different ways. So it's 0.5 times 10 to the third. So that would be 500 of an absolute lymphocyte count.
Last question.
I hate that thing. I have a. Would you stop that, Stuart? I can't stand microphones. Question about biotin again. I know Marie takes biotin, and I don't know what type of biotin she takes. I have a friend who's getting some that is formulated, like in the lab. Is one better than the other?
Yeah, I don't know the way. So the clinical trial that was done, there, of course, as a company that's making a new MS treatment, they're going to be very tight-lipped about how they're making this medication. So we really don't know. We know what the dose is, but we don't know how it's formulated, how it's released, what other things are in the pill. The stuff that you buy at the health food store is just regular old biotin, so I don't have enough information to give you on that. There are always there are pharmacists. Back in the old days, pharmacists took things and put them in pills, and you could they had big jars on their shelves, and if you wanted biotin, they'd make you biotin. If you wanted B12, they'd make you B12, and in whatever pill form you wanted. There are patients that can't take they're allergic to certain fillers in regular medications, so the pharmacist will order the actual compound, and they will make the pill without the fillers that the patient's allergic to. And so there are pharmacies that will put together, whatever you want them to, 300 milligrams of biotin in a capsule. But we just don't have enough information yet.
I think that's it.
All right, thank you, Stu.
Thank you.
And I didn't pass out. That was
You didn't what?
I didn't pass out.
You didn't pass out. That's good. I actually thought that you were going to be nervous up here. You were, see? Thank you to all of you for coming down here tonight. Everybody have a great night. Thank you for being here.